Good afternoon, everyone, and welcome to the GenQA Focus On webinar, where today we are going to review the current published guidelines for reporting, and also we're having a Focus On webinar on striving for the perfect genomic test report. I'm Sandy Deans, I'm Director of GenQA, and I have great pleasure to be joined today by two colleagues within GenQA and also co-authors on the guidance document. That's Melody Taberner and Becky Tracy. So we're going to walk you through some of the changes that we made to the previous guidance document and also take some question and answers at the end of the session. And also integrate some of the guidance into how we run our GenQA external quality assessment schemes and apply the guidance documentation to our marking criteria. So really sort of what's happening in the real world and applying any guidance to real genomic test result reports. So next slide, please. Thank you, Jenny. So the agenda today, I'll start by giving you an introduction around the new guidance document and summarise the changes to previous recommendations. Then we're going to move on to how this fits in with external quality assessment, looking at genotype and analytical nomenclature, why that's important, specifications of tests performed, and the interpretation of those results. We're also going to share with you some of the common errors that we come across whilst assessing our schemes and give some examples of good reports or good caveats and text that are applied within a report. We'll go through some of the general marking criteria and really address the fact, does this cause harm to the patient? Because we don't just make deductions or comments just for the sake of it. There's actually a real reason there and the background to why we give that feedback. Then we'll have our live Q&A session and we'll be joined with some of the other scientific members of GenQA staff. So just to put in context, once the slide comes up, about why we have held this Focus On webinar and why we did an update to the current recommendations. So at that time last year, I was the chair of the European Society of Human Genetics Quality Subcommittee, and we were asked as a quality subcommittee to review and update the then current 2014 recommendations for reporting results of diagnostic genetic testing, and that included biochemical, cytogenetic and molecular genetic results. And the idea was that since 2014, we all know that genomic testing has evolved and really at pace, and that the practice that was currently recommended through these guidance document was very much becoming out of date. So there was a real need there really to look at the guidance and refresh within the context of current genomic testing practice. So these are the a screenshot of the current guidance that was published this year. It's open access article, and we would encourage you to look and have a good read through and hopefully be able to apply the guidance to your own laboratory reports. In the guidance document, we start off with a very high level summary of the updates that we've made to the documentation, just to make it easier to find where the changes are. So one of the first areas that we focused on was the clinical information that accompanies the samples. So we were very clear that we removed the minimal set of clinical information that needs to accompany the samples. And really it's because we're aware that each laboratory has your own local requirements for sample acceptance. So the authors agreed that the document should focus on the information required for the report rather than sample receipt, because we don't want to deter from any well thought out and implemented local practice. So here we focus on the relevant details required to be present on the report. We then go into a lot more detail onto the content of the report, so the administrative side of what needs to be on the report, so we know who it has been tested and why being tested. The identification to make sure that not just the patients are identified, but the samples that have been tested is known. Also what the clinical question is being asked and to address those, and also the test specifications. And we'll go into all of these elements in a bit more depth today. We also have updated the contents of the report section, giving much clearer guidance on the required interpretation of the results. And also we've discussed more fully about the reporting of variant pathogenicity and the classification. This is something that has evolved tremendously over the last few years, following on the back of different guidance documents and guidelines that have been published for different variant types. So we thought it was very important that we started to look at how these should be incorporated or not, and how much detail should be incorporated into the report. We've also covered the fact that sometimes no clinically significant findings are detected, and how we report this in a safe way, how we deal with incidental findings, and recommendation for further testing. Reporting results from testing of multiple individuals has also been updated in line with the current GDPR. And we also included new sections to cover the issue of amended reporting, and also those reports informing the conferring clinician that the samples have been stored. So it's clear to say that we have focused predominantly today's webinar on the reporting more of cytogenomic and molecular inherited diseases rather than biochemical disorders, but the guidelines are applied to biochemical genetic results as well. It's also important to see that the authors were a mixture of individuals with different expertise in areas of knowledge and past experience. So we had clinical scientists, both in the field of cytogenomics, molecular genetics and biochemical genetics. We had some biochemists, we had clinical geneticists, as well as bioinformaticians. So really we wanted to have a full input of all the different elements that come together and expert knowledge to create a genomic test report. Also, we had individuals from different countries, and I think it's important that these are European-based guidelines to ensure that they are generic and can be applied in the different contexts of international and national guidance. So these are the summary of the principles that have been applied while generating this guidance document. It was acknowledged that there's national recommendations in place, and this guidance was intended to complement those already in use. So it's not the instruction that these guidance points should be followed in absolute 100%. Really, it's about pragmatic guidance and recommendations to be applied within your national context. It's also recommended that specific guidance on reporting such results is sought. So, for example, there are very specific ways to report particular test results, for example, pre-implantation genetic diagnostics and genetic testing, and thereby we would definitely recommend that you use this guidance document in conjunction with specific guidance, who obviously is further tailored more specifically for particular tests and referrals. The basic principles of reporting genomic results are outlined, and I think really one of the take-home messages is about succinct reports. We must consider this now, because due to the huge growing volume of data that we generate in the laboratory, it means that we can no longer make it feasible to format the report in a very narrative way with a lot of explanatory text. So it's about getting the right message across in a safe way. So in a snapshot here, I like this diagram because it gives a very simple way of remembering all the different elements that we need to think about when we're generating a report. It needs to be a very clear result so you can find it easily and you know what that result is. It needs to be concise rather than being across multiple pages, so you can actually find that result and interpretation. It needs to be accurate and correctly reported using standardized nomenclature to aid in accurate reporting, understanding of the result, and also to be able to integrate into the emerging and many databases that are now so critical for our interpretation of variants. We also need to see fully interpreted reports, because obviously the test being performed really has to be determined the outcome within the context of the clinical case scenario, why it's being tested. And that follows on, you need to answer that clinical question. And really, there's no point having this wonderful report if there's any misinterpretation or any chance that you could misidentify who the report's referring to. So really it has to be robustly identifiable to be clinically safe. The report needs to take into account these 4 different areas, and here I've mapped the section numbers to the recommendations. So section 3 is concerned about the definition of a report. So this is a formal medical document, and we need to make sure it has at least this basic information. So it needs to go back to the referring clinic physician. It potentially is read by healthcare professionals and acted upon. It also often goes back to the patient and maybe cascaded across different family members. And it's also integrated into healthcare records. So we need to take into account who is the reader and to ensure that all these different elements are addressed so nothing can be misinterpreted and it's really very clear what the message is. We also need to be aware of who and what was tested. So there's 2 clear sections within the document addressing patient identification and sample identification. We also need to understand why the test is being performed. So why are you performing this test? And I get a section addresses restating the clinical question and making it very clear which question you are answering. Then we need to look at what test was performed. So there's a very now extended section within the document that focuses more on the specification of the test performed and the limitations of those tests as well. So moving on, the administration side, I'm not really going to go into this much detail because there's a lot of finer details here, but this is just very much a word diagram just to show you all the things that we need to think about. We need to look at clear identifiers, the names, the sample type, the gender of the person being tested, the date. That can mean things from the date of sample receipt, the date of collection, the date the report is authorised and issued, who's authorised that, and multiple issues here that just gives a very high level snapshot. So I'm going to move on from administration because I think a lot of that will be addressed later on when we talk about EQA marking. So to look at what happens in the real world, that's sort of putting the context into what we would like to see and what the general recommendations are from the European paper, but just drawing on some of the experience we have from our EQA participation. We see a huge range of different formats of reports, and I think we have to be pragmatic and understand that a lot of laboratories are limited into with the format of the report purely along the basis of which LIMS system they're using. It's not necessarily the LIMS that they would like to use, but probably something that has been inherited or its infrastructure is linked into other laboratories within their hospital or healthcare system. So we're aware that people are restricted and not necessarily using the system that they would prefer. However, this is an example of one of the reports that was submitted for one of the BRCA EQAs for molecular testing, and it's an 8-page report. And I think even though you can't read the text here, I think you would all agree that this is very extensive and really not very user-friendly to find where the result is and what result and interpretation that constitutes. So I think we would definitely safely say that we would steer away from such an extensive report. On the other flip side, a small concise report may be ideal, and here's an example of one, again an EQA submission from one of our laboratories whereby they were testing for a BRCA1, BRCA2 gene variant. A variant was detected, it clearly states the variant there, and it was a pathogenic variant that was detected. However, there are many things missing from this report. Next slide. The first one really is to say, why were you doing this test? What was the reason for referral? It purely just says test was BRCA1, BRCA2 testing, but we don't know what context this is. Is it a diagnostic test? Is it a predictive test? So these things are really important when you're interpreting the results. The next issue was we don't actually know what was tested. Nowhere on the report does it say what type of sample, when it was collected, date of receipt, and a lot of this information is required to meet ISO 15189, which is the international standard for medical laboratories. It's important to know what sample you're testing, particularly if it's not not a germline sample, and there's limitations of detecting variant due to sample type. Also, date of collection and date of receipt in the laboratory. Has it been around the hospital system for a couple of days, a couple of weeks? And that obviously will determine the quality of the sample you receive and test. So it's important that this information is also included on your report. Then we move on to where's the interpretation? We've got a very clear result here, but what does it actually mean? And then also, is there other things we need to think about, other testing and family risks, particularly with BRCA1, BRCA2 testing, where we know there's a real risk of inherited cancer predisposition here to cancers. So I think it's important that the interpretation needs to be included. However, saying that, we are aware there's some particular countries or healthcare systems set up where there is a standalone laboratory testing service which would not provide any clinical interpretation. However, this result would then go into a clinical service and would be interpreted before it's cascaded onto the family and reported back to the individual. So what has been tested? Here we've got methodology. It says MiSeq Illumina. Now that's the next generation sequencing platform. It doesn't actually tell us what's been tested, whether it's single nucleotide variants, whether it's indels, whether it's copy number variants. And a lot of this information is incredibly important, particularly when no variant has been detected, just to understand how to interpret that result. And really what has not been tested is just as important to understand than what has been tested. So that really leads us now on to more of the nitty-gritty and the real details of the guidance document. So I'm going to hand over to my colleague Melody, who is going to talk through the specifications of the tests. Thanks, Melody.
Thank you. So we're going to look in a bit more detail now at how the tests performed should be specified on the report. So the information on the methods used, as Sandy said, does need to be concise, but it does need to be sufficient detail for another scientist to reproduce the results and for readers to understand what has actually been done and the limitations of what has been done. So, like we say, this information needs to be concise and it should not detract from the clinically relevant aspects of the report. So you might choose to provide this kind of detail in footnotes or appendices, or it might be available on a document-controlled website. But the main point to get home is that this information needs to be present on the report, but it should not detract from the clinically significant information. Where applicable, the technical sensitivity and the practical resolution should be provided on the report, and these aspects should be based on internal data or validation testing as appropriate. You should state any commercially available kits which have been used and any software packages used for the analysis, and you might choose to include a list of variants which were included in those kits. So obviously the methods used will vary depending on what tests have actually been performed. So I've just put a few details down here. So if you're doing a microarray test, you would need to describe the microarray platform. So the design of the platform, the manufacturer, any version number of the kit, how many probes are within that kit. You might choose to describe the exons and which exons have been screened and which transcript those were in when you're looking for pathogenic variants. If you've done a carrier typing test, really you should be saying that you've used G banding rather than one of the other banding techniques. And for FISH tests, it's important to list the probe manufacturer as well as the probe name. There are some manufacturers who produce multiple probes for the same kind of gene, and they do have differences and their own different limitations. So it's important to state both of these things. And as an example, this is something that we quite commonly see in EQA. So participants will submit reports stating which FISH probe has been used, but they'll omit the manufacturer, and that would be given a 0.5 deduction in interpretation. So where applicable, obviously the technical sensitivity and the practical resolution would also need to be provided to complement the method details. So for a microarray test, you could describe the average resolution. Again, that might be available on the manufacturer's website, but what's important is what you've actually done with that technique. What have you analysed at what resolution? And we call that the practical resolution. You would state the detection rate of a particular variant in the population of origin. Really, you should also be stating the banding resolution in karyotyping tests, and this is something that is now within the new recommendations. Historically, cytogenomic reports haven't really contained much detail about the method and the sensitivity of that method, but when we look at them across the whole range of genomic testing, really these cytogenomic reports should also be including that limitation. This is obviously a newer thing, and participants are used to obviously not putting this information in the report, so there aren't any EQA deductions for this at the moment, but now that is present in the recommendations, that's something that we need to look out for and we will consider deducting in future. For karyotyping, you might also need to state what limit of detection for mosaicism and the confidence in that level. And also, particularly in hematological reports, it's very important to state the cutoff levels for any FISH tests that you're doing, so that the low-level results can be interpreted correctly. So here are some real-life examples again. So I've just picked out, obviously we can't cover all of the different methods that are used in genomic testing, but I've just picked out a few examples to just give you an idea of what the genomic report really should be containing. So here we've got a nice example, a nice concise rider that would be added to a microarray test report. So this again, it will probably be placed at the bottom of the report to not detract from the clinically relevant information, but it includes everything that somebody looking at that report needs to find out what was done and the limitations of it. So they're stating what microarray was used, the manufacturer, the version, the actual possible detection, so a 15 kb resolution, with all the 665,000 probes. They've stated the software which was used, the version and the genome build. And then there's a short paragraph about the limitations of the test. So obviously arrays will not detect balanced rearrangements or SMVs. So there's a clear statement of the limitations of the test. And at the bottom is what they've actually done with the output of that test. So although the gene resolution might be 15 kb, routinely they're screening for deletions greater than 200 kb and duplications greater than 500 kb. And this sort of practical resolution might vary depending on whether it's a postnatal test or a prenatal test. So here are some other examples. So again, we've got all the correct information, so the manufacturers, the versions, the array design, the human genome build, that kind of thing. But importantly, what is missing here is the practical resolution of the array test. And again, this is something that we commonly see in EQA, and these would be given 0.5 deduction for omitting the practical resolution of the microarray test. This is an example of a cystic fibrosis test. So here they've stated again the manufacturer and the version number, and they've chosen to list the variants. Obviously, I haven't copied them all out here, but they've chosen to list the variants, so it's very clear what that kit contained and what was tested for in that CF test. And here we have some whole genome sequencing test methodologies and limitations. So here they've noted that the sensitivity of the test is limited by the types of the detectable pathogenic variants and the regions of low read depth coverage and incomplete ascertainment of disease gene associations. And here's an example where they've chosen to say that read depth coverage is available on request. So there's an opportunity for the reader to find that out, but it's not cluttering up the report with extra information. So all those things that I've just mentioned are really, really crucial, particularly when reports are stating that there are no detected variants. Again, on clinical review, it might be in a few years' time, the report is reviewed by the clinician. They'll be able to see exactly what was done at the time of the previous testing, if there are any changes, if it's worth doing a different test now that maybe was not available before. So it's really, really important to have a clear message of what was done and the limitations of that testing. But obviously, a key component of the report is actually what the result was. So we're going to look at that now briefly. So the results must be presented in a brief and unambiguous form, a clear statement on the report of what the result was. To help, again, other readers understand and to integrate results into databases, it's advisable that internationally agreed nomenclature, such as the ISCN or HGVS, is used. We are aware, obviously, there are scenarios where there might not be currently nomenclature. So, for example, OGM testing, there is no nomenclature for that currently in the ISCN. Or it might be that a laboratory chooses to maybe not use the FISH nomenclature and instead write a clear summary statement of the result, because sometimes the nomenclature can actually be quite confusing itself, although scientists may understand it, some more than others. Sometimes you just wouldn't expect a clinician or maybe other healthcare workers to be able to understand the nomenclature. So the result needs to be written in a clear way, and if nomenclature is used, it needs to be described in words as well, so that everybody reading the report can understand the result. The use of the terms positive and negative are discouraged. Again, you'll get a comment in your EQA submission if you're using those, and we state that pretty much on every EQA summary report. It just could cause confusion, and it would be better to phrase it slightly differently. It would be okay to use legacy or historical descriptions. Sometimes these are now clearer than the newer nomenclature, so these may be included for clarity. And also it would help to compare results of a current test of a proband with, with a parent with maybe that of a proband done a few years before. It's important, particularly for tandem repeat disorders, to include the reference ranges of the expansions and to cite the source where these were from. So any test like that, you need to make sure you're looking for the reference ranges and including them again so that the results can be interpreted correctly. And for tests which involve looking at multiple genes, so for example, copy number variants, so a large copy number variant might include a huge list of genes. It might be that you choose not to list all of those genes in the report because there's just too many and it distracts from the clinical content. So again, judgment should be used, it should be pragmatic. The key information needs to be there, but the report needs to be clear. So for EQA, obviously I've mentioned a few of the deductions that might be given. So for example, a fish manufacturer and some comments, but really you would be given a critical analytical or genotyping error if the result for the patient that has been reported is incorrect. So if the result could lead to serious clinical consequences, or if it implies a significant lack of diagnostic skill or scientific knowledge on the part of the participant, then a critical error would be given for analysis or genotyping. So we've looked at reporting the results. Now we're going to look at the interpretation of those results, and I'm going to hand over to Becky. Thank you.
Thank you, Melody. So just to follow on from what Melody has said about critical analytical or genotyping errors, similarly, we have a critical interpretation error. And this is a very serious error which may result in the harm or change the clinical management of the patient or their relatives. So I'm just going to look a little bit about things to think about in your reports that should be included to ensure that all the important aspects of interpretation are there. So one of the first things to think about when you're including interpretation in your report is that obviously each patient is an individual, and that the interpretation is solely for them. So we're thinking about the age of the patient, the reason that this test was referred, their clinical picture, who the referring clinician might be. So those are all the things to think about in the background. But also, there are a number of more generic points that you can think about when you're writing your interpretation for these reports. So overall, we want to provide an answer to the clinical question that has been asked in a clear and concise way. And as I said, thinking about the context of the relevant clinical and family information for that patient, as well as where possible, either integrating or cross-referencing the individual results for a number of tests if they have been performed for that patient. Because obviously it's more useful for a clinician to receive a single report which summarises the results rather than a number of different reports. Highlight a conclusion, whether this is in bold or underlined or in a text box, so that it instantly draws your eye to that part of the report. And it needs to be written in such a way that it can be understandable by different clinical professionals, because although that report may be going back to the referring clinician, it will go into the patient notes and can end up being read by a number of different clinical professionals, some who may have more knowledge of genetics than others. It needs to contain all the relevant and, importantly, up-to-date information required to interpret that result. So what did you use to get to that result? What literature resources? What reference sequences? Which databases did you look at? All of those kinds of things may be important. Again, it obviously very much depends on the nature of the results and the nature of the test that was performed. You may also wish to think about indicating which further tests or other family studies may be appropriate, as these may provide additional information or improve the accuracy of the interpretation for that patient. So on the right-hand side here, I've just included an example from another report of the interpretation that was given. So you can see they've given an awful lot of information about the testing that was done. So there are a number of things here which could be improved in this report. For instance, they have used rearrangement positive, which, as Melody explained, is terminology that we would not encourage because it can be confusing. They've also included an awful lot of information to do with the number of tumour cells with different patterns. So all of that information, whilst if you wish to include it in a report, it might be better being included perhaps in a summary table as opposed to being in the interpretation part of the report. So you also need to think about how you interpret your results based on the results that you have obtained. So for instance, if you're looking at a patient who has a new diagnosis which you have found of a pathogenic variant for, you need to be clear within that report that that result potentially has important implications for other family members. But again, we need to think about where this is appropriate. Obviously, if a patient is adopted, then that's going to be of less importance because there may not be any information on other family members. Where appropriate, perhaps also think about recommending testing of other family members, such as the partner or at-risk relatives. Again, this may depend on the age of the index case or the situation of the index case. Include the risk for future offspring, or recommend testing of both parents to determine carrier status, particularly for autosomal recessive disorders, where 2 variants have been detected, to ensure that you can confirm the diagnosis in their child. and also to think about offering prenatal diagnosis or pre-symptomatic testing. But again, all of this is subject to local recommendations and guidelines as well that different countries may have. Equally important are reports where no clinically significant findings are detected. And in these reports, it's really important to state that rather than stating that the patient is normal or negative, as again, this can lead to confusion. It is recommended not to include benign or likely benign variants, as again, these can potentially lead to confusion. One of the most important things to do in these kinds of reports, though, is to state what has been tested and with any limitations. This is important because it is possible that more testing may be performed on this patient in a few months or in a few years. And without having that information on the report, it's difficult to determine what was done previously or what was not done. The other thing to consider is that stating other further appropriate investigations which could or should be considered. Again, this varies across different countries and laboratories as to what might be included in a report, bearing in mind that some laboratories send this information back to clinical teams who would then include that information themselves. Other types of reports are also equally important, such as where you have incomplete or failed testing. And again, it's important to state that the test has failed or is incomplete, but also what was done and what wasn't done. What were the limitations of the tests that you performed? And once again, thinking about further recommendations and requesting a repeat sample. Should that be of the same sample type, or would another sample type actually work better? So there are other things to consider. And then finally, there are some other scenarios that are included in the recently published paper, which I'm only going to touch on briefly here. And these are reporting incidental findings, how to report interim results, ensuring that it is very obvious to the clinical team that these are interim results. And then equally important, when you publish a final report stating that it is the latest result, providing an overall interpretation which may include results that were published in the interim reports, and also stating that this report supersedes the interim report which was previously published. A few other things, such as each individual should be reported on a separate and unique document, and also how to deal with amended reports and sample storage reports are covered in the publication. So I think that draws to a close the presentation part from myself, Sandy and Melody. And I think we're now ready to move on to the questions.
Thank you very much, both of you, for a whirlwind tour of the recommendations document. I think we'd also like to thank not just Becky and Melody, but also our co-authors. That's Book, Isabel, Els, Mick, Luca, Katrine and Christy for all their help and support getting this document together. It was very much a team effort, so thank you everyone. We have got some questions coming in, so again, I'll please ask you if you want to ask anything on the science team, then please do. Do the rest of the GenQA members want to put their cameras on so we all see who's here with us? Would be great. We've got Jenny and we've got Dave, and I think we've got Mark as well, and Farah, and I think Fiona. So we've got the majority of the team here, so thank you everyone. Yes, questions are coming in fast and furious. The first thing I would like to ask the attendees, and I know you can't respond and talk, but we are looking at generating a suite or a set of example good reports. across the board, and I think we would like to hear from you if that would be a good idea, and if you have any suggestions of examples that you would particularly like. So maybe pop them in the questions box as well, if there's a yes or not required, or yes please for arrays, or yes please for next generation sequencing, multiple things like that. So the first question I'm going to kick us off with, which is probably across the board, is about reporting class 1 and class 2 and potentially class 3 variants. Should they be on the report? Should they definitely not? Is it definitely one recommendation fits all? Who wants to kick us off there? Becky, maybe do you want to start from the NGS side with Dave?
I think it is generally accepted not to include class 1 and class 2 variants. Dave's nodding, so that's good. And I think different labs deal with class 3 variants in different ways. Depending,
it's important to say whether you do report class 3 variants, yes, or whether you don't report them. That's pretty important. Yeah, but I'd agree, class 1 and 2 generally wouldn't be on the report.
Great, thank you. So that's for single nucleotide variants, because you both come from the molecular side. What about copy number variants and structural variants from the other side? I'm going to come to Mark first, who'll kick us off, and then maybe Fiona can answer from the hematological side of the world.
Yeah, the same is true for the CNVs as for the SNVs, in that generally class 1 and class 2 are not reported. Class 3 is optional, but you should be stating what your guidelines are for reporting them. And if you do report them, there should be some interpretation to go along with that.
Great, thank you. Fiona, what about in the hematological malignancies reports? Is that the same?
Well, it's very much a hot topic just now, isn't it? It's trying to decide how to classify the variants in haematology and what should be reported. So it's maybe not as succinct as class 1, class 2, class 3 at the moment. It's more based on the size being over a recommended. So if the CNV is over a certain size, or if it includes a specific gene. Currently we're using Jacqueline Schuman's 2016 recommendations. So obviously we'd like to see updates to them sometime soon, but that's basically the paper that we would refer to for reporting variants.
Great, thank you everyone. We've got a question here, Melody, probably come to you because you've mentioned it in your part of the presentation, is are labs expected to create their own in-house cutoffs for FISH probes, or can we use those provided by the manufacturer?
Yes, so there will be some probes where the manufacturer will provide cutoffs. I think it would be important for you to verify those cutoffs within your laboratory. I think we are all aware that analysts score things slightly differently. It is a subjective test sometimes. Sometimes somebody will pick up on an abnormal signal pattern early on in their analysis, and that might skew their results towards that, whereas somebody who's not seen it till a bit later might not find as many cells. So I think that it would be a lot of work to do that in your own laboratory for every single analyst, but I think there should be some verification or maybe an audit just to regularly check different people's results and check that there is harmonisation between the different analysts, and ensure that those cut-off levels that you are reporting are robust and relevant.
Great, thank you very much, Melody. We've got one here going back to classification of variants. So a question, are there recommended classification systems for array and/or whole genome sequencing CNVs and SV results? Mark, do you want to take that one?
Yeah, I can take that one. So usually we use the information in Riggs et al. For the CNVs. I can't remember the paper for the SNVs. Maybe Becky can tell us what the paper is for the SNVs.
Oh, Richards et al.
I couldn't remember the name. So yeah, there are papers out there that we tend to use when we're creating our marking criteria, and which we would actually recommend that people use.
And also just to flag the SNV classification criteria is currently being updated, and it's going to be more aligned to the copy number variant mechanism and put some sort of scoring system in place. So we will have some webinars in 2023 once those recommendations come out, and we can start seeing how they're applied and give some guidance to everyone as we start adapting to different guidance out there. Okay, here we have one here so I understand that interpretation might be important for pathogenic or likely pathogenic variants detected. However, we're running panels, particularly for myeloid and lymphoid diseases. So do we need to provide interpretation for all variants detected? So I think that's specifically targeted, Fiona, to you for Hem-Onc, but maybe it is relevant also in arrays and NGS. So Fiona, first of all, for hematological malignancies.
So with regards to the hematological malignancies, it would be the, as you say, the pathogenic and the likely pathogenic that's reported. But what a lot of the participants will choose to do is include either a reference that other CNVs were detected but classified as benign, and a record of these can be obtained, or some people will just put it in as a little box depending on how many findings there were to say that these were detected and of unknown clinical significance. So we wouldn't expect a full interpretation of every variant necessarily, but it's quite nice to have them classified in a group at the bottom, or at least indicate that the participant could access them if they needed it.
Great, thank you very much. And what about in the context of arrays? Mark, do you want to answer that one?
So if you're doing panels, again, I would only report the pathogenic and likely pathogenic, and obviously it's optional whether you report the VUs. If it's not directly related to the clinical question, then I probably wouldn't include the VU on that.
Yeah, okay.
I think you need to bear in mind any incidental findings. I think that's the difficulty here. So they need to be dealt with individually, and there needs to be a policy on how you're going to deal with incidental findings, which you obviously can find in an array test or a panel test.
Absolutely. Okay, thank you. So one here specifically about STRs. So you mentioned about putting ranges on the report for STRs. So that's do you envisage this being the case where whole genome sequencing has been the testing strategy and a lot of STRs have been included? So it could be quite cluttered. Is it okay to say ranges can be provided where needed? And I think this is part of the bigger picture also. Do you start listing all the genes that are in your 200, 300 gene panel? Do you list everything that's on your maybe virtual panel that's been applied to your whole exome sequence? So Becky, will we come to you for that one first of all? Initial thoughts?
I think that's a really good question. I guess there are different ways that you can tackle this, and we see some of this already, don't we? Some labs either put a link to their website where they have all of this information on there, or they have it as an additional page on their report of kind of, you know, supplementary information almost. I don't think it's our role to be prescriptive as to what labs should do, but I mean, clearly that information needs to be available, and it also needs to be accessible as a date-related package as well. So this is what we were testing at that point in time. So that if you do go back to that patient, particularly in the case of patients where nothing significant is detected, you know what was included and what wasn't.
Yeah. And Clara, is that what we're seeing? I know you're currently coming out at the end of the assessing of the 2022 molecular genetics schemes, inherited disorders. Is that what you're seeing? Is everyone, you know, condensing the reports and cross-referencing to another resource, or are we getting long reports with everything listed?
No, I don't think the reports have been really long. They are quite concise and they're good. Obviously, if you're reporting a result where there's a pathogenic result has been found, it's more it's helpful to include the reference or what the repeats mean on your report, but as Becky has said, some people do have a link to their website or somewhere where the information is accessible. We haven't really had issues where this information is not available, so people are reporting really well.
Great. Oh, that's good to know. Okay, we've got quite a few things here about one in particular about reporting a carrier finding in a young child, and I think this is some things that we do rotate Farah and Dave when we do the rare inherited disorders EQAs. We set different scenarios, so it potentially could be a child being tested for a diagnosis, or it could be a carrier test in a young adult. So this is a reporting a carrier finding in a young child where they may need genetic counselling in adulthood. So should this be specifically included at the time of reporting on the child, or would a statement that the family and parents should be referred as a whole for genetic testing and counselling be sufficient? So for example, like a Fragile X premutation in a young male with developmental delay. How extensive, I think, is the question, should that guidance and interpretation be? Farah, do you want to?
I can
Dave?
start with that. Okay,
Go
sorry.
on.
Go.
Again,
Well, we
I
had
would say it's
okay, go on.
important to be clear about what you are including, what you aren't including. And say you're doing a predictive test and you weren't reporting carriers, you were just reporting if they were affected or not. I think it's just important that if you're not reporting carriers, that it's clear that you're not reporting carriers. So I think it also depends on, I mean, there's guidance, there's very strict guidance on this in some places and not in other places. And obviously you have to stick to the guidance for where you are. But I think as long as it's clear on the report, one way or the other, whether you are or whether you aren't, I think that would probably be the most important thing, what Farah thinks.
Yeah, so just to add, actually, one of the CF cases this year was exactly what has been described, and we saw at all different ranges, and none are essentially wrong if you're if it's clear what you're doing. So some people submitted their policy to say it's not up, but we do not report in minors, and that's fine. We wouldn't, no deduction, no penalty for that, because that's your policy. Some worded their report in a manner whereby it was clear that they hadn't missed the other variant, and they just weren't reporting. How can I? Well, look out for the report. It's really interesting, the CF report. I will add that. But the way you phrase it is, so it was clear that nothing's been missed, but they do say at a later age, do follow up. There can be follow up. So it's clear that you are encouraging them to come back. It's just dependent on your policy, but your policy should be clear.
Great, thank you. So I think it's in the context of your local policy, particularly your national guidance or local hospital guidance, and what your clinical service is requesting as well. Great, thank you both. Okay, Jenny, I'm going to come to you. We've got one here around sarcomas and integrated reporting, and I think this is something that's very hot topic. We always support integrated reporting, and we've been asked, are there any plans to assess integrated reporting? And I think we say yes, definitely. We're working very closely with our colleagues in UK NEQAS, leukocyte immunophenotyping, who deliver quite a lot of the hematological malignancy EQAs for small nucleotide variants, and we're working with them closely to see how we can have an end-to-end assessment of hem-onc testing and MDT review and that outcome of the integrated reporting with particularly SIHMDS services. We're also looking at integrated reporting in the context of MDT working as well, which I think is important, particularly when you're doing whole genome sequencing or whole exomes and large panels, having that clinical input. So integrated report as in the clinical interpretation being added, and other particularly say biochemical tests to see what that end product was. So that's very much something that we're focusing on. But Jenny, the question to you is, what if the reports written do not usually provide an interpretation, for example, for a lymphoma or a sarcoma case, which would be given in an integrated report, which would be written by the pathologists? And it considers the pathology, the immunohistochemistry, etc. So bringing all that information together. So could labs potentially lose marks if their interpretation is generally given in an integrated report rather than in the genetics report itself? So what do we actually do? So I suppose it's about EQA being an artificial stop process without having that integration.
Yeah, I think we've had lots of discussions with this in sarcoma, although the feeling that has always been put forward is if you're reporting these reports as standalone reports, they need a degree of interpretation on them. It doesn't have to be a final interpretation. It doesn't have to be an actual integrated interpretation or anything like that. But I certainly think that recently we have seen evidences of reports where there's no interpretation, and I don't think the pathologist could actually interpret what's been written in the report. And this is when it comes to reporting of particularly fusion transcripts and the like in NGS, and there's no interpretation, presumably because it goes to a pathologist or someone else to do the interpretation, but you need to interpret the actual results you have in the context of the test you're doing. So it's not just about the final clinical interpretation, it's about the interpretation of why you're doing that test.
Yeah, thank you, Jenny. And I think it's something that, as I mentioned, we are aware of, and yeah, other colleagues, of how we can maybe reflect the real world more in our EQAs. Yeah,
I think it's quite difficult with the idea of the pathologically integrated reports as well, because they're I think they're quite individual as well on how different departments and different centres do it. So that is more tricky, and it depends on who's doing the testing where as well. But we do appreciate that, and we do take that into account if laboratories tell us. But with the caveat, it's still supposed to be a standalone report. So if you produce a standalone report, you need to have something on there.
Yeah, thank you, Jenny. Can you pop us onto the next slide then, please, Jenny? I think we're coming up to the top of the hour now. We've had great interaction. Thank you for submitting the questions. There's some there that hopefully we've covered the majority of them because of some of the common themes. And we have taken on board a lot of yes pleases for some example reports, particularly across the whole remit of all the EQAs that we do. So we'll see what we can do there. So watch this space. These focus on webinars. We will continue to provide them during 2023, but obviously we want them to be of use to you. This one today was in response to the guidance document coming out, and also can we apply that how we work with the EQA assessment. So thank you for that, and hopefully this has ticked the box and delivered what you needed. And the focus on topic for January is going to be around genetic counselling, discussing our clinical genetics EQAs and our new genetic counsellor EQA. So hopefully if you're that's not your area of expertise, but you're very welcome to join and pass on the information to colleagues as well. So it just finally to say thank you to the whole GenQA team and the technical team behind the scenes who've made this all happen, and for the input. For Becky, Melody, and the rest of the co-authors of the guidance document, a huge thank you to them, and also thank you to you for joining today and participating. So thank you, and we look forward to your continued EQA participation. Bye all.